Hi and welcome to the channel Love Obstetrics and Gynaecology. In today's video, we'll learn how to fill and interpret the WHO Modified Partograph, a vital tool in labor monitoring that helps us track the maternal and fetal well-being during the childbirth. So let's dive into this step-by-step clinical guide. The first thing that we fill is the particulars of the patient. This is the only way we can be sure that we are monitoring the right patient and the specifics are related to her. Next thing we have is the fetal part, the fetal heart rate, the liquor, the molding. Next, the labor specific columns come up, that is the cervicogram and the fetal head descent, both starting from the 4 centimeter, the cervicogram starting from the 4 centimeter dilatation, and the descent is from the 4/5 of the fetal head, that is palpable abdominally. The next most important column is the time column, and the time is mentioned in hours. And in hours, basically this is the first column that we have to fill. Each big column depicts 1 hour, and if we split that column, it is into a 30-minute interval. Next up we have the contraction monitoring column, the oxytocin drops, if we have given, so we have to mention that specifically at what drops per minute the rate of flow of oxytocin. Next column is for the drugs in the IV fluid, and the last columns are for the specifically for the maternal aspect, mentioning specifically the blood pressure and the heart rate, and also the temperature, the urine including the volume, acid, the amount of any acetone present or the protein. Now let's fill the partograph. You will require all of these following details. So this is my case-based scenario that I'm going to discuss. Firstly, we will fill the registration column, the particulars of the patient, the registration number, her name, and the age, that is 30 years old, and finally her date of admission, the obstetric formula, and the LMP ADOD, making her gestation as 38 weeks 6 days. The membranes were intact and she was in a 6-hour duration of labor. Once we have filled the particulars, we come to the cervicogram, which actually starts at the 4 centimeter dilatation. We have thoroughly assessed this patient and confirmed that she is already 5 centimeter dilated, so she qualifies for inclusion in the partograph. Now coming to the cervicogram, which is where we plot the cervical dilatation. This is marked as an X and we plot it at 5 centimeter on the alert line at the time of admission, which is at 8 am. The alert line further progresses at 1 centimeter per hour, and there is also one more line, that is the action line, which is drawn approximately 4 centimeter to the right of the alert line. Each large column on the partograph represents 1 hour, and we will continue monitoring the labor at regular intervals. And here we're talking about specifically the cervicogram. It has to be monitored every 4 hourly. Now moving on to the uterine contractions, these are assessed over 10 minutes. On initial assessment, she had 3 contractions in 10 minutes, each of moderate duration, that is between 20 to 40 seconds. So I have plotted these contractions using the 3 shaded vertical bars in the contraction section, and each bar represents 1 contraction with diagonal lines used to denote the moderate intensity. Next, we plot the descent of fetal head. On abdominal examination, the fetal head was 2/5 palpable above the symphysis pubis, indicating the descent. We mark this with an O directly below the same vertical line where we plotted X for the cervical dilatation. So this completes the initial plotting of the cervical dilatation, uterine contraction, and the descent. The next vaginal examination will be performed 4 hours later to further assess the progress. Ideally, the progress should remain to the left of the alert line. If it crosses into the space between the alert and action line, we need to monitor it closely, and if it crosses beyond the action line, an obstetric intervention may be necessary. The contractions, on the other hand, are monitored every 30 minutes, with each assessment covering a 10-minute window, making this one of the most frequent but crucial component. Now discussing the oxytocin administration. So at this point there is no indication to initiate the oxytocin as the patient is progressing spontaneously and is still aligned with the alert line. Additionally, the fetal heart rate, though not plotted on the demonstration yet, is within the normal limits. Therefore, augmentation with oxytocin is not recommended at this stage. Moving further down the partograph, we have the section for the drugs and the IV fluid. Since the patient presented in active labor and is stable with no current intervention initiated, so no IV fluid or medication has been started so far. Now we move on to filling the blood pressure and the pulse column. The blood pressure is marked by using the two-way arrow. The upward arrow denotes the systolic pressure and the downward arrow represents the diastolic pressure. In this case, the patient's blood pressure was 130/70, and then we have connected the two ends with a line. Just adjacent to this arrow, I mark the pulse with a dot that was at 90 beats per minute, and further we keep on monitoring the BP for 2 hours and pulse for 30 minutes. And as we move forward in time, the pulse was next then 100 beats per minute, then 90 beats per minute, 82 beats per minute, again 90 beats per minute, and each of these value is represented with a dot joined sequentially to create a visual thread of the maternal pulse. Now we move on to the recording of the maternal temperature, which is monitored at every 2-hourly interval, and the temperature can be recorded either in degrees Celsius or Fahrenheit. Here we have recorded it in Fahrenheit as is 97 Fahrenheit on admission. A rise in temperature can be important clinical signature as it may indicate maternal dehydration or critical condition such as obstructed labor, intrauterine infection, sepsis, both of which require immediate attention. Next is the urine output section. So urine output is mentioned in ml every 2-hourly, and also we have to assess for the protein and the acetone, and in this case no proteinuria or ketonuria was there, so I have marked it with simple dash in both the columns. Now we come to the most crucial section, the fetal monitoring, which includes the fetal heart rate, liquor and molding. These components directly or indirectly provide us the information regarding the fetal well-being. Starting with the fetal heart rate, it is recorded as dot just like pulse and is monitored every 30 minutes. So here the first recording is done at 8 am. The same time we have plotted the X on the cervical dilatation. The fetal heart rate was at 140 beats per minute, so I am going to just plot a dot on the 140 beats per minute line and along with alignment with the X that we have marked on the cervical dilatation, and we then further monitor it at every 30 minutes interval. The partograph features bold lines at 160 and 110 beats per minute, clearly making the normal fetal heart rate range, and these boundaries help us quickly identify if there is any sign of fetal distress. Next we document the liquor. Here we had the membranes intact, so I am going to just put an I, and the molding cannot be further assessed as the membranes were present. So just simply indicating a dash, and further this monitoring was continued. The labor progressed, and at 11 am I observed the presence of meconium stained liquor, which I have mentioned as M with the red circle. During an unscheduled assessment which was done earlier than the routine for our cervical check, which should have been at 12 pm, so at 11 am I found out that she was fully dilated. So I am going to mark an X to the left of this alert line at 11 am. So this makes my cervicogram move towards the left of the alert. Throughout the partograph, you can see that the fetal heart remained within the normal limit, the liquor status changed to the meconium, and the molding was absent. So now I am going to show you the three zones, the green, red and yellow zones. The green zone to the left of the alert line, this is ideal. The yellow zone between the alert and action line, which requires a close monitoring, and the red zone, it represents that we have to take some action, whether it has to be in the form of augmentation of labor or the cesarean section. Focusing specifically on the fetal monitoring section, we noted the presence of meconium stained liquor during the labor. This finding required immediate reassessment of the cervical dilatation, descent of the fetal head and uterine contraction. So let's assess these one by one. See, the fetal heart rate remained well within the normal range of 110 to 160. The cervical dilatation, if we talk about, it was fully dilated and at 10 centimeter. So this is also good. The next thing is the fetal head descent. The fetal head was also well descended and not palpable abdominally, so it's 0. And further we assess the uterine contractions. So there were 4 contractions every 10 minutes of strong duration, sweet duration, which was also good. So, all this indicated that the labor was progressing well with no signs of obstruction. There was no need for labor augmentation. However, meconium stained liquor warranted a close monitoring. So, as the patient was in second gravida with full dilatation, I expect her to deliver within the next 15 to 30 minutes. And therefore, we initiated a continuous CTG monitoring to closely observe the fetal heart rate pattern. So, in the next half an hour, the labor progressed normally and the patient remained to the left of the alert line throughout. At 11:30 am, she spontaneously delivered. So now we have to write the delivery outcome, specifically mentioning single, alive, the gender of the baby, the date, time, birth weight, try, and it will be very good if we can write the APGAR score. These details are just documented adjacent to the cervicogram and the descent part. So as you have seen in this video, the WHO Modified Partograph is a simple yet powerful clinical tool. It allows us to detect the abnormality early, intervene at the right time, and most importantly, ensure the safe delivery of both mother and the baby. So this one partograph has many benefits: early detection of prolonged or any kind of abnormal labor, timely decision, improved maternal fetal outcome, simple and cost effective. Thanks for joining me on the channel Love Obstetrics and Gynaecology. Please do like, subscribe and share this video, and also comment on your queries regarding the partograph and your personal experiences regarding the partograph, and see you in the next video. Thanks for watching.